Okay. Good evening, everybody. Today's webinar is started. I welcome our Secretary, Dr. Periyaswamy, to host the welcome address.
Yes, sir. Yes, sir. I am online.
Okay.
I am audible?
Yeah.
So good evening to all. On behalf of ISA Pudukkottai, it's to extend my warm welcome to this 5th online CME. This is an online continuous education program of ISA Pudukkottai, named as Pudukkottai Budan. This is a fifth successful program. I thank all the participants and speakers, those who are attended the first 4 meetings. I thank everyone for this successful program. Already we conducted 4th CME program with the eminent speakers from various parts of the country. This is the chart of this past 4 programs, and this is the 5th program. Here we are having great good eminent speakers from JSS Medical College, Mysore. They are going to talk about neuromuscular monitoring, anatomy and physiology of neuromuscular junction, and residual neuromuscular palsy. For that, here I welcome our former professor and HOD of Tirunelveli Medical College and Emeritus Professor of Dr. MGR Medical University, Dr. M. Kannan. I welcome you, sir, on behalf of ISA Pudukkottai, sir. And I welcome Dr. Archana, Professor, JSS Medical College, Mysore, and Dr. Vaishnavi, Associate Professor of Academic and Research Institute of JSS Medical College, Mysore, and Dr. Maitreyi Gandhi, JSS Medical College, Mysore. I welcome you all, madam.
Thank you, sir.
Thank you. And this is a protocol to thank our academic chairman, Dr. Meenakshi Sundaram, for this every week successful ongoing program. And I thank and welcome our President, Dr. Suresh Kumar, and our Treasurer, Dr. David, and all participants, PGs, and consultants from various parts of this nation. I welcome you all, people. And today we are going to have this neuromuscular monitoring and neuromuscular palsy. Nerve and muscle meet each other. Sodium and potassium channel open the gate further. Acetylcholine and adrenaline-like catecholamines act as neurotransmitter. They initiate action potential and involve every movement of our life. With this, I thank you everyone and successful best wishes for this successful program. Thank you, sir.
Thank you, Dr. Periyaswamy. Respected Secretary Periyaswamy, respected Academic Chairman Dr. A.L.M. sir, today's chairperson Professor Dr. Kannan from Tirunelveli Medical College, eminent speakers from JSS Medical College, Dr. Archana Madam, Dr. Vaishnavi Madam, and Dr. Maitri Gandhi Madam, respected treasurer Dr. Dravid, the participants, delegates, and there is a term, if you want to have a hit in the head, you should have a hit by our Guru. So respected Dr. Guru Dutt, you have joined us today. As a president of our ISA Pudukkottai branch, once again I welcome you all for this 5th seminar. The topic chosen is a wonderful one. In our postgraduate days, we will be searching, we will reading everything, and we will searching for whoever to taught this neuromuscular junction. I was really fascinated that this neuromuscular junction is being two specialists were competing. One anesthesiologist and another one neurologist. But anesthesiologist is a different person in tackling this neuromuscular junction. I compare with a traffic policeman who is organizing these traffic signals in the road junction. He will manipulate the traffic. If he wants, he will stop the traffic. If he wants, he facilitates the traffic. Likewise, we anesthesiologists in our day-to-day life, we manipulate the neuromuscular junction. We facilitate, we stop. Again, we facilitate. Whatever we do with our technical and experience. So at this juncture, this topic chosen by our academic chairman and our secretary, I once again thank both of them. And the chosen people, the eminent speakers from JSS Medical College, who were none other than can take the topic to a very good level, and it will be definitely useful for the postgraduates and assembled delegates. Once again, I thank you all. Thank you all. I next hand over the proceedings to our academic chairman, Dr. A.L. Meenakshi Sundaram sir. Thank you. Thank you.
Thanks, Mr. President, sir. Respected President and Secretary Treasurer of ISA Pudukkottai, and our honorary guests, Dr. Gurudat, Dr. Kannan, Dr. Vaishnavi, Dr. Archana, and Dr. Maitri Ganti. Good evening to everyone. And initially, I thank all the delegates who are participating in this program. At the outset, this topic is fascinating, and I should thank Dr. Gurudat personally, because he has selected this topic, and I have got a very good name with that. Many postgraduates informed me that this sort of a topic they have never expected, and they profusely congratulated me for selecting the topic without knowing that these sort of intelligent topics will not be selected by me. And I thank personally the JSS team, because I had been to JSS, that medical college itself is very good. And whenever any person is joining in any of the surgical post-graduation in JSS, we used to call Dr. Gurudat. Same way, one person has graduated MS General Surgery from Tamil Nadu. Even now, our Maharashtra Dr. Varsha's son has joined MS Orthopedics. Then I said, I will inform the anesthesia team. But she said, I have met Dr. Gurudat and he has given the warm reception. So that JSS, academically, even I had been there to deliver lectures. They are very good for so many years. And now, whether our neuronal system is intact or not, they are going to talk about neuromuscular junction. And these people are very keen. I have labeled the topic for Dr. Archana Madam as neuromuscular junction monitoring. And she called me and said, sir, it should be neuromuscular monitoring. And I was happy both the ways. Even we are checking the proof with the faculty, and they are also very keen. And my special thanks to Dr. Vaishnavi Madam, because she is going to talk about the anatomy and the physiology, which definitely many of us are not aware. Except Gurudat and Kannan, I think many of us is not aware what is what. And Dr. Archana Madam, once she explains how the neuromuscular monitoring is functioning, then I have to check whether my neuromuscular monitoring is correct or not. And I differ from our president, even though ourselves and the neurologists are competing for neuromuscular junction, the neurologist always likes to have the neuromuscular monitoring to progress. It should be active. But anesthesiologist is the only faculty we want to abolish everything, whether it is a protective reflex or whether it is a neuromuscular monitoring. We want to block everything and we want to abolish everything. In that way, we are different. And I profusely congratulate Dr. Maitri Ganti, the youngster, tomorrow's assistant professor, associate professor, and a professor. And she has to set an example for the future postgraduates, how to behave a good teacher. So with this few words, I hand over the proceedings to Dr. Kannan. And you know, Dr. Kannan is a great academician. And I know Dr. Kannan sir for more than 25 years. And he is always with the evergreen smile on his face. So even as an assistant professor, I know him. Even as a professor, I know him. And because of him only, I have selected my promotion postings at Tirunelveli. I don't know anyone. Even I was a little bit disturbed because after having settled in Tanjavur for 2 decades, I was promoted to Tirunelveli. I don't know any area down south Madurai, but Dr. Kannan, who is a Chennai person, settled in Tirunelveli, and he only consoled me, you please come here, Tirunelveli is a wonderful place. And because of his instructions only, I have joined Tirunelveli Medical College, and he has treated me as his guest, and it was a home away from home for me. He is a professor emeritus for the Tamil Nadu Dr. MGR Medical University. He was a former governing council member of ISA National, and in all academic programs, he will be the keynote speaker. And I thank for Dr. Kannan for gracing this occasion, and I hand over the proceedings to Dr. Kannan. Sir, please.
Thank you, Dr. Meenakshi Sundaram. I am audible?
Yes.
Am I audible?
Yes, sir. Yes, sir.
Thank you. Thank you, Meenakshi Sundaram. Thank you, ISA Pudukkottai, for inviting me as a chairperson for this interesting topic. The topic is neuromuscular junction. Ever since the curare is introduced, it created a lot of interest for the anesthetist to learn about the neuromuscular junction. Of course, all of us are aware it is a South American arrow poisoning, which was first when introduced into Europe. It is Carl Bernard who postulated it works in the neuromuscular junction. And of course, subsequent persons proved it to work in the neuromuscular junction. Only as late as 1942, it was introduced in anesthesia by Griffith and Johnson. And there was a lot of sea of changes in anesthesia and surgery because of this neuromuscular junction. For instance, intubation is possible, controlled ventilation is possible, which made the surgery perfect and fast and successful. Of course, it is a double-edged weapon. You know well that death due to NMD receptors or due to inadequate reversal, that is still it is a problem. Certain disease like conditions like myasthenia gravis, it is a problem, and also malignant hyperthermia, it is a problem. All of us you are aware. And monitoring the neuromuscular junction, I mean NMD or the muscle relaxant, is done mainly for academic purpose in practice. It is not done as routinely. Why? The reason is now we have good ventilators are available if the patient phenomena, because we should every time we should be aware why the muscle relaxant, the depth of the muscle relaxant in some delicate surgeries like eye surgeries, neurosurgeries, and it is very mandatory, very much mandatory. And reversal of this drug is also very as important as any other thing. So we have very good eminent speakers, probably students from Gurudat. And the first speaker, Vaishnavi, to deliver about anatomy and physiology of neuromuscular junction. Over to Dr. Vaishnavi, please.
Thank you, sir.
Yes, Vaishnavi, please.
Yes, sir. Am I audible, sir?
Yes, ma'am, you are audible.
Yes.
Okay.
You are audible.
Yes. So at the outset, a very good evening to all of you. And I start my talk by extending my thanks to the ISA Pudukkottai branch and the organizers for giving me a chance to deliver a talk in this August gathering today. I also extend my heartfelt thanks to my HOD, Professor Dr. Gurudat, for his guidance, encouragement, and support. A very warm welcome to all of you and a namaste. It is this namaste that we are going to decode today. A seemingly simple folding of hands is in fact the result of a series of intricate events taking place all the way from the brain through the spinal cord to the muscle, with the nerves carrying the impulses. Welcome to the world of chemicals, signals, currents, and fascinating functions, the neuromuscular junction. This will be the outline of today's talk. The neuromuscular junction is also known as the myoneural junction. It is a specialized unit where the efferent nerve ending and the muscle membrane come in close proximity. Both the structures have undergone modifications so that they can carry out the function effectively. And that function is the smooth transmission of the signal by electrical and chemical means to finally result in an effective muscle contraction. We'll start with the presynaptic apparatus, that is the nerve ending. The motor neuron starts from the ventral horn of the spinal cord and travels as a thick myelinated axon. As it reaches the muscle, at the terminal, it loses its myelin, it starts multiplying repeatedly, and it gets enveloped by the Schwann cells. It has certain sites called as the active zones for the transmission of the impulses. The other important component are the vesicles, which contain the neurotransmitter acetylcholine, that is the chief chemical messenger. And there are also certain important channels which bring about the voltage changes necessary for the transmission of the impulses. The gap between the motor nerve terminal and the nerve terminal and the motor end plate is called as the synaptic cleft or the junctional cleft. It is about 50 nanometer wide and it contains the basal lamina, basal membrane, and acetylcholine esterase. This basal lamina are filamentous proteins which span across the neuromuscular junction and help to keep the nerve ending and the muscle membrane in tight alignment. The postsynaptic apparatus consists of the motor end plate. So this has invaginations called as the primary and the secondary cleft. They are abundant acetylcholine receptors at the shoulders and sodium channels deep in the cleft. This nerve to muscle contact is 1-to-1. That is, each muscle cell has contact with only one nerve ending and it is durable. So much so that even when the nerve gets damaged, the regenerating nerve develops in the exact same region as the previous nerve. The only exception to this 1-to-1 contact are the extraocular muscles. This is because these muscles need to be in a tonic state of contraction to maintain the steady position of the eye. Hence, these muscles have more than one neuromuscular junction. Now, as I told, the nerve comes and it has multiple branches at its end. Each branch interacts with the muscle cells. So all the muscle cells and the nerve ending together form one unit. So when the nerve carries the impulse, all the muscle cells are stimulated by it and they undergo synchronous contraction. This is called as the fasciculations. And I'm very sure all of us are very familiar with the succinylcholine-induced fasciculations. The peri-junctional zone. This is the area in the immediate vicinity of the neuromuscular junction. This carries certain important clinical implications. So this explains how the normal contraction takes place by propagating the action potential which is generated at the neuromuscular junction to spread across the muscle membrane. Also, this explains the biphasic effect seen produced by the depolarizing muscle relaxants. This is because of the presence of a large density of sodium channels, which are more sensitive to the voltage changes than to the presence of the acetylcholine at the neuromuscular junction. We'll be dealing more in detail with this in the later slides. So coming to the synthesis of the acetylcholine, the main neurotransmitter here. So this is synthesized mainly in the neuron. It has all the raw materials and the synthesis takes place in the cell body. After synthesis, it is transported across the axon. Finally, it is stored in the nerve terminal in the form of vesicles. So choline and acetylcoenzyme A react to form acetylcholine. The reaction is catalyzed by choline acetyltransferase. Choline is obtained from the ECF, acetylcoenzyme A from the mitochondria in the nerve ending. Once it is formed, it is stored in the vesicles. These vesicles are nothing but the storage bags of acetylcholine. Each vesicle carries a whopping number of 10,000 acetylcholine molecules. And they are stored in the vesicles till a stimulus arrives. Once the stimulus arrives, the acetylcholine is released from the vesicles and the vesicles are recycled. Now these vesicles, they have a lipid bilayer and they have channels and regulatory proteins on their membranes. There are two pools. One is the readily releasable pool, which is ready to be released when the stimulus arrives, and then a reserve pool, which is as a backup. Depending upon how long the vesicles stay open and how they behave after they have released their contents, they can be classified as the piss and run type, the compensatory type, and the stranded type of vesicles. So to explain in a very simple way, when the nerve impulse travels and reaches the nerve terminal, the vesicles are activated, which then go and fuse with the nerve membrane, and they burst open and release their contents, that is acetylcholine, into the nerve junction. To explain it more in detail at the molecular or the cellular level, when the nerve terminal is depolarized, the sodium ions enter the nerve, and this in turn opens the calcium channels. So the calcium inside the cell increases. This increased intracellular calcium is sensed by special proteins called as the Snare proteins. They in turn activate the vesicles and cause them to dock, fuse, and discharge their contents at the active zone. So after the release of acetylcholine, the vesicles are disassembled and recycled. So this explains the exocytosis of acetylcholine. The importance of Snare proteins, we realize that in conditions of botulinum toxin or the tetanus toxin poisoning. In these conditions, what happens is that the Snare proteins are digested by these toxins. So there is no longer activation of the vesicles, even though the calcium has entered the nerve terminal, and there is no exocytosis of the acetylcholine. So clinically, it results in chemical denervation and the muscle weakness and the paralysis. What happens to this acetylcholine that is released? This binds to its specific receptor on the shoulders of the cleft seen in the motor end plate, and it is a very potent messenger and carries out its function. But it is short-lived. It is rapidly deactivated by hydrolysis by the acetylcholine esterase in about 1 to 2 milliseconds. This acetylcholine esterase is the enzyme responsible for degradation of acetylcholine. It is present in the synaptic cleft, but however, it is prepared in the muscle under the motor end plate and remains attached to it by the protein strands. It is important to note that in congenital disorders of the enzyme, it results in symptoms similar to myasthenia gravis or other myasthenic syndromes, and the acquired abnormal function is seen in organophosphorus poisoning and the nerve gas poisoning, or even with the long-term administration of pyridostigmine as a prophylaxis in the nerve gas poisoning. So in these conditions, the symptoms present as chronic fatigue or even muscle weakness. The acetylcholine receptors. We all know that they are of two types, the muscarinic and the nicotinic. So it is the nicotinic receptors that are present at the neuromuscular junction. They are present both presynaptically and postsynaptically. Postsynaptically, three isoforms exist: the mature or the junctional form, immature or the extrajunctional form, the neuronal alpha-7 nicotinic receptors. All these receptors are synthesized in the muscle cell and anchored to the end plate by a protein called rhabsin. They consist of 5 subunits arranged like the staves of a barrel. This is how the receptor looks like. It consists of 5 subunits. They are all arranged like a barrel, and in the center there is a gap which acts as the ion channel. There are 2 alpha subunits, beta and the delta subunit, which remain common in the mature and the immature receptor isoforms. So coming to a few differences between the junctional and the extrajunctional receptors. The junctional are the mature type seen in the adult muscle fibers. They contain the epsilon subunit, and they are more stable, having a metabolic half-life of 2 weeks. They are present normally at the neuromuscular junction only. Whereas the extrajunctional receptors are the immature types, which are present only during the fetal life, but sometimes reappear in pathological conditions, and they are more unstable. That is, they have a half-life of a very short duration, 24 hours only. And instead of the epsilon subunit, they contain the gamma subunit. Another important feature is they can be present not just at the neuromuscular junction. They are present anywhere along the muscle membrane. So as I already told, the immature forms contain the gamma subunit and the mature forms contain the epsilon subunit. So the immature isoform, they have long channel opening times, but they have low conductance currents. Whereas the mature form has short opening times, but they have a high amplitude current conductance. The alpha 7 nicotinic receptors have 5 subunits, and all the 5 are the alpha 7 types. So it is important to note here that all of these are resistant to atropine because it is a muscarinic antagonist. However, they are sensitive to the muscle relaxants and alpha-bungarotoxin. And the least resistant or the least sensitive among all these are the alpha 7 nicotinic receptors. So coming to the functioning of the receptors, as already mentioned, it has 2 alpha subunits, and both these subunits should be simultaneously engaged by the ligand, that is acetylcholine. Only when the specific binding sites are engaged simultaneously by acetylcholine does the central channel open and the movement of ions take place. That is, the sodium and the calcium ions move in and the potassium ion moves out. Coming to the neuronal alpha 7 subtype, they have 5 subunits and all the 5 can bind to the ligands. And they are present in the fetal life when the muscle is still present, still developing and present without innervation. Once the innervation starts happening and the muscle matures, they gradually disappear. However, they also reappear in pathological states. They have certain unusual functional and pharmacologic characteristics of clinical implication for the anesthesiologist. One thing is, once the succinylcholine or the acetylcholine is degraded, choline is one of the metabolite formed. This choline acts as a full-fledged agonist at this particular receptor isoform. Second thing is, even when it is continuously engaged by the agonist, it does not cause any desensitization of the receptor. So what happens as a result of this? There is a continuous efflux of the potassium. So this explains the hyperkalemia which is seen with succinylcholine administration in certain pathological conditions. The second unique feature is of the 5 subunits, since all of them can bind to the agonist and antagonist, even if 3 are occupied by antagonists, 2 are still available to engage the agonist and cause contraction. So we see a relative resistance to the non-depolarizing muscle relaxant. Coming to the pre-junctional acetylcholine receptors. They are of the alpha 3 beta 2 subtypes. They contain only the alpha and the beta subunits, and their main effect is that they exert a positive feedback loop. That is, once they sense that the acetylcholine is there in the cleft, that is synaptic junction, they cause the release of more neurotransmitter into the cleft by the nerve endings. They have implications in several actions that we see, like for example, the succinylcholine induced fasciculations and in priming. It is seen that when the non-depolarizing relaxant is given before giving succinylcholine in a small dose, in these small doses, the non-depolarizers preferentially bind to the presynaptic receptors and they prevent the positive feedback loop from taking place. So as a result, when we give succinylcholine later, it is not able to bring about the fasciculations. Similarly, the tetanic fade and train of 4 fade also is explained by the reaction with the pre-junctional acetylcholine receptors. So an important aspect that we need to know is about the re-expression of these immature and the alpha-7 nicotinic receptors in certain pathological situations like denervation, immobilization, sepsis, burns, etc. So if we can see on this image here, in the upper image, this is a normal innervated muscle where the receptors are present only at the neuromuscular junction. Whereas in the denervated or the injured state, the immature and the nicotinic isoforms start developing all along the membrane. So what happens is, because of this upregulation, the channels, the succinylcholine starts reacting with the receptors all along the membrane and not just at the NMJ. So this causes the channels to open, and so there is continuous efflux of potassium, resulting in dangerous hyperkalemia and malignant arrhythmia. As I already told, the succinylcholine unfortunately reacts with all the receptors that are there all throughout the membrane. So the immature isoforms are sensitive to succinylcholine, whereas the alpha-7 receptors, they're sensitive to succinylcholine but resistant to non-depolarizers. Coming to the electrophysiology, we'll first see with the pre-junctional events that take place. Once the action potential reaches the nerve terminal, there is an inflow of sodium. This in turn causes the calcium channel to open. The increased intracellular calcium is sensed by the Snare proteins. This causes the docking and fusion and release of the vesicles. So the vesicles then release the acetylcholine into the synaptic cleft. Once the acetylcholine is released, the potassium channels open in the nerve terminal. They stop the calcium current and thereby the vesicle release. The vesicles are then recycled. And acetylcholine then binds to the postsynaptic receptor, causing the ion channel opening there, and the wave of depolarization spreads. We have some important ions which bring about this voltage changes. The sodium channels, which bring about the initial depolarization and initiate the calcium channel opening. The calcium channels, which stimulate the vesicles to release acetylcholine. These are of two types, the P type and the slow L type. P type is the one which is majorly present in the neuromuscular junction. The slower L types are mainly present in the cardiovascular system. Then the potassium channels. These are like the speed breakers. So they don't allow the calcium to be continuously entering the cell. They limit the duration of depolarization, thereby the calcium entering the acetylcholine release. So they are again of two types, the voltage gated and the calcium activated. So these calcium channels, one thing is the amount of extracellular calcium that is there decides the quanta of acetylcholine released. So if the extracellular calcium is more, then more than the required amount of acetylcholine continues to get released. And this further is augmented if we are to give potassium blockers, because the potassium channels which act as the speed breakers are inhibited from doing their action. And so the calcium current gets prolonged and calcium goes on entering the cell. Some important clinical syndromes are there because of abnormalities in these ion channels. The Eaton-Lambert myasthenic syndrome is because of acquired autoantibodies to the voltage-gated calcium channels. Here, the calcium current and the subsequent vesicle activation and acetylcholine release doesn't happen because of the autoantibodies. So this results in muscle weakness, clinically seen as increased sensitivity to the depolarizing and non-depolarizing muscle relaxants. Similarly, the presence of excess amounts of the bivalent cations, like for example, magnesium. So we can take the example of preeclampsia. So in preeclampsia or eclampsia, magnesium sulfate is the treatment of choice. Once that is given, magnesium is present in more than the normal concentration. So it competitively reacts with calcium and prevents calcium from binding to its ion channels. So this binds to the ion channels, calcium channels, and inhibits the calcium binding and impairs the neuromuscular transmission. So if we are to give GA to such a patient who has come for some surgery like this cesarean section, the magnesium sulfate, which is already being given to the patient, will potentiate the weakness caused by the muscle relaxants. Another important thing is the calcium blockers used clinically, like nifedipine, nicardipine, etc. They do not have any effect on the P channels because they act mainly on the slow channels present in the CVS, especially when used in the clinical doses. So coming to the electrophysiology at the post-junctional site. So once the alpha subunits are simultaneously engaged by the agonist, there's a conformational change with the twisting movement and opening of the channels for the ions to move. Sodium and calcium come inside and potassium moves out. So the net current is depolarizing and it creates an end plate potential. So this end plate potential, the depolarizing current travels all along the muscle membrane and stimulates the muscle to contract. So once this depolarizing current or the action potential reaches the T tubules, it stimulates the sarcoplasmic reticulum to release the calcium. This calcium released activates the troponin and causes the actin-myosin cross-bridging and the final effect of muscle contraction to occur. Once the acetylcholine is removed from its binding site, then tropomyosin comes into action and it covers the active binding sites on actin and relaxation occurs because the cross bridges are broken down. So this is important because clinically, if there are defects in the calcium channels in the sarcoplasmic reticulum, that is the defective ryanodine receptors, it results clinically in a condition called as malignant hyperthermia. Because what happens is that the calcium channels are defective. So they go on releasing the calcium from the sarcoplasmic reticulum. So this continuous calcium release causes a continuous prolonged muscle contraction and ATP breakdown and a lot of heat generation. This is what we see clinically as the elevated body temperature and increased muscle rigidity, the masseter muscle spasm, so classic of the malignant hyperthermia. Coming back to the post-junctional electrophysiologic events. So once the agonist detached from the receptor site, the pulse stops and a reverse mechanical conformation takes place. This opening of the channel is a central event because that converts the chemical signal to an electrical signal and results in muscle contraction. It is important to note that if only one site is occupied at the receptor, then the channel remains closed, and this forms the basis for action of the non-depolarizing muscle relaxants. And whether there will be the agonist action or the antagonist action depends upon the concentration and binding characteristics of the agonist and the antagonist, which are present at the neuromuscular junction. So to summarize the electrophysiology of the NMJ, the nerve terminal, the nerve terminal gets the action potential. Once it reaches the nerve terminal, it stimulates the calcium channel opening. Calcium enters inside the nerve terminal. It goes and activates the snare proteins on the vesicle, causes them to fuse, dock, and release the acetylcholine. This goes and binds with its receptor on the motor end plate, causes the channel to open. Sodium and calcium go in, potassium goes out. So this wave of depolarization travels across, reaching the T tubules, activating the sarcoplasmic reticulum and causing the calcium release, which further brings about the actin-myosin bridging and the muscle contraction. So coming to the action, or rather the interaction between the drugs and the acetylcholine receptors. As I already mentioned, in the normal circumstance, acetylcholine should bind to both the subunits to cause the channel to open. If acetylcholine is to bind to only one subunit, the channel remains closed. If it is a non-depolarizer binding to one subunit, even then the channel remains closed, even if the other subunit is to be occupied by acetylcholine. So let us see how the non-depolarizers react. They act mainly by competitive inhibition. So the relative concentrations will decide whether it is the agonist or the antagonist which gets the upper hand. Now, at the start of surgery, when we give a non-depolarizer muscle relaxant, the concentration of non-depolarizer is more than that of acetylcholine. So that gets an upper hand and competitively binds to the receptor, blocks the transmission. Towards the end of the surgery, when we want to reverse the block, we give cholinesterase inhibitors like neostigmine. So the concentration of acetylcholine increases in the synaptic cleft because its breakdown is inhibited by the cholinesterase inhibitors. Since acetylcholine is more now, and there is a competitive reaction there, acetylcholine gets an upper hand over the non-depolarizers and it binds to the receptor site and the block is reversed. Now, mathematically, if the non-depolarizer concentration is doubled, then the cholinesterase inhibitors have to be given 4 times the dose, which means a large dose has to be given, and which is not to be done. So this is the reason why we say that the muscle relaxant should not be reversed at a deep plane or a deep level of block. We should allow the non-depolarizers to detach from the receptor site or to undergo a bit of metabolism and the patient to come out slightly before we give the reversal agent. This is only for the cholinesterase inhibitors, that is the neostigmine. Cyclodextrin, gamma cyclodextrins like the Sugamadex are the newer reversal agents. They do not depend upon the concentration for their actions to take place because they act by encapsulating the relaxant molecule there. And the latest wide spectrum reversal agent is Calabodione 2, which again does not depend upon the concentration. Coming to the action of the depolarizing muscle relaxant. The most commonly, or in fact, the only depolarizing relaxant in clinical use is succinylcholine, which is nothing but the 2 molecules of acetylcholine fused together at their backbone. It has several similarities with acetylcholine in that it binds to the acetylcholine receptors, it opens the channels, passes the current, and depolarizes the end plate. And like acetylcholine, it attaches only briefly. But it also has certain differences. It is not hydrolyzed by cholinesterase, and even though it attaches briefly, it again binds to another receptor. So there is repeated binding and depolarization at the end plate. And the most important difference, it has a biphasic action. That is, it initially causes a muscle contraction followed by flaccid paralysis of the muscle. So we'll understand how this biphasic reaction takes place. For this, we need to know the function of the sodium channels in the peri-junctional zone. These sodium channels consist of 2 gates, the upper voltage sensitive gate and the lower time-dependent inactivation gate. In the closed state, the upper gate is closed. In the open state, both the upper and the lower gates remain open and allow the sodium to pass across. In the inactivated state, the time-dependent lower gate remains closed, but the upper gate remains open. So this forms the basis for our understanding of how succinylcholine produces a contraction followed by relaxation. So once succinylcholine is given, initially it causes the neuromuscular junction to be depolarized and causes this the wave of depolarization and the transmission to take place. So the muscle contracts. So the channels are the sodium channels in the peri-junctional zone. As I already told, they are not sensitive to whether the neurotransmitter is present or not. They are only sensitive to the voltage changes. So the neuromuscular junction is depolarized. So this activates the sodium channels in the peri-junctional zone. They open and the voltage gate and the time dependent gate both open and the depolarization takes place initially. However, the time dependent inactivation gate closes after some time, though the upper gate is still open. So sodium can no longer enter inside. Hence, the contraction stops. So what happens now is that the end plate is continuously depolarized by succinylcholine because of its repeated binding with the receptors. And the peri-junctional zone, the sodium channels being sensitive to the depolarization taking place at the NMJ, only the upper gate is open and the lower gate is closed. Hence, it is frozen in an inactive state. The rest of the muscle is free from the effects that is taking place at the NMJ and the channels remain in a normal state. Thus, the peri-junctional zone acts as a buffer zone, protecting the rest of the muscle from the events taking place at the neuromuscular junction due to succinylcholine. At this stage, even if we are to give a burst of acetylcholine at the NMJ, it still cannot change the inactive sodium channels to their normal state. This phenomenon is called as accommodation. Other than the muscle relaxants, there are certain other drugs which exert their effect of muscle relaxation or blocking the nerve transmission at the neuromuscular junction. These drugs do not fit in the classic model. That is, they do not bind to the acetylcholine binding site. However, they do bring about changes in the dynamics of the receptor by altering the ion flow and distorting the end plate potential. And most importantly, the action of these drugs cannot be antagonized by the the usual routine cholinesterase inhibitors. So they act by something called as the desensitization block and the ion channel block. So what is this desensitization block? Here, the agonist binds to the acetylcholine receptor, but does not bring about any conformational change to open the ion channel. Now, the receptor, because it is engaged by this agonist, cannot engage acetylcholine, and acetylcholine cannot open the channel even if it binds to the receptors. These receptors are called as desensitized receptors. So this brings about weakening of the neuromuscular transmission, reduces the margin of safety, and also augments the non-depolarizing muscle relaxant induced block. This phenomenon also partly explains the phase 2 block. The ion channel block can take place on an open channel or a closed channel. In closed channel, the agonists block the mouth of the channel and prevent the ion passage and subsequent depolarization. And in open channel, the drug molecule binds to an open channel. It enters the open channel and blocks it and impairs further ion passage. Examples include lidocaine, calcium channel blocking drugs, and neostigmine. An important thing to note here is some drugs like tubocurare, they act as agonist to the binding site, antagonist to the binding site in small doses, and they can block the channels at the larger doses. That is, in small doses, they will bind to the acetylcholine receptor binding site and exert the normal action. Whereas in larger doses, they will block the channels also, ion channels also. So this is the list of the various drugs that bring about the desensitization. Of extreme importance to us anesthesiologists are the volatile anesthetics and the local anesthetics, mainly lignocaine. So we usually give a reversal drug at the end of general anesthesia when the patient shows small spontaneous efforts. After giving this, while waiting for the patient to come out fully, we usually give lignocaine to attenuate the rise in the blood pressure. But we notice that after giving lignocaine, there's a slight decrease or even cessation of the spontaneous efforts. This is because of the desensitization and the ion channel blocking effect of lignocaine that I just now explained. That is, lignocaine can cause the open ion channels to be blocked because it goes and sits in the channels and prevents sodium from entering the channel, and also by binding to the receptor and desensitizing it so that it is no longer reacting and responding to acetylcholine. The next thing is about volatile anesthetics. So when we use volatile anesthetics along with the muscle relaxants, what happens is there may be a delay towards the end, especially if we use volatile anesthetics in high concentrations. This is because the volatile anesthetics exert action at various levels. They have a depressing action at the central level. They also have a presynaptic effect, and postsynaptically they exert a desensitizing effect. So because of this, the neuromuscular blocking action is augmented. And that is why we have to titrate the dose of the muscle relaxants we give when we are using volatile anesthetics also. Because and thus it helps to give a balanced anesthesia in a proper way. That is, we are using volatile anesthetics and muscle relaxants to both to provide the muscle relaxation. However, to delay the to prevent the delayed recovery, we should titrate the dose of the muscle relaxant so that the recovery is prompt. A word about the phase 2 block, which is seen with the continuous administration of succinylcholine. So this is a complex phenomenon and has multiple mechanisms, which involves interaction with nicotinic receptors or the post-junctional acetylcholine receptor block. It could be even because of the continuous efflux of the potassium and influx of sodium, causing electrolyte imbalance and distortion of the junctional membrane function. Calcium also can cause disruption of the receptors and the sub-end plate elements. Several factors are involved, and those include the drug, concentration, the duration of exposure, and interaction with other anesthetic agents. It is not sure whether by giving cholinesterase inhibitors, the phase 2 block will be reversed. The final action is actually unpredictable. And as per the latest recommendations, it is told that we should not attempt reversal with the cholinesterase inhibitors. Thank you.
So it is, there is no questions in the chat box, I believe. Am I audible?
Yes, sir.
Yes. So I have few doubts. One doubt that you said the fetal receptors are alpha 7, which are resistant to non-depolarizing muscle relaxation. Am I right?
Yes, sir.
Your statement. But
Yes, sir.
newborn and infants are very sensitive to non-depolarizations in clinical practice.
Yes, sir. Because by the time of birth, it is greatly replaced. Once the muscle innervation starts taking place, these alpha 7 nicotinic receptors greatly disappear. So the mature forms start developing. So by birth, almost it's mainly the mature forms.
At birth, even
At birth.
even in premature children, it is resistant to. I mean, they are sensitive to non-depolarization.
Sir,
Premature children, but they are very sensitive to non-depolarization. Yes.
sir, Chairperson, sir.
Yes, sir.
We can have the discussion at the end, sir, so that put together we can ask the questions.
Right, sir. Right, sir. Thank you, sir. Thank you. So next, I invite Dr. Archana to highlight that about monitoring neuromuscular junctions.
Good evening, sir, and good
Good
evening to all the participants. At the outset, I would like to thank the Pudukkottai branch for inviting us to give this talk. And I also like to thank Dr. Meenakshi Sundaram and Dr. Gurudat sir, our beloved HOD, who has given me the opportunity. Thank you, sir. So I'll start my talk now. So just a minute. So can you see?
Yes.
Yes, sir. So my today's topic is neuromuscular monitoring. So Churchill-Davidson initially said the only satisfactory means for determining the degree of neuromuscular blockade is to stimulate a motor nerve with electrical current and observe the degree of contraction of the muscles innervated by that nerve. This was said by Churchill-Davidson in 1958. So that's when the monitoring of neuromuscular transmission was thought of. But however, it was not until the train of 4 pattern of stimulation, which was described in 1970 by Ali and his colleagues, that such equipment came into the use. So why neuromuscular monitoring is necessary? So it improves the quality of intubation. It reduces the airway injury. It helps in maintaining adequate neuromuscular blockade, and it also helps in diagnosis of the residual paralysis. The residual paralysis occurs even with the use of intermediate acting non-depolarizing relaxants, despite the routine use of anticholinesterase reversal agent, because almost up to 20 to 40% of the patients coming to PSU would have residual neuromuscular block. So there are numerous clinical studies which have documented because of incomplete neuromuscular recovery, there were associated adverse events like airway obstruction, hypoxemic episodes, post-operative respiratory complications, intraoperative awareness, and unpleasant symptoms of muscle weakness. So where neuromuscular monitoring becomes very important. As we all know, neuromuscular monitoring is not mandatory according to ASS standards. So why, but in some situation, it becomes really necessary to do neuromuscular monitoring. Like when you are used prolonged infusions of neuromuscular blocking drugs, or when long-acting neuromuscular blocking agents are used, or when surgery or anesthesia is prolonged, or when inadequate reversal may have devastating effects like severe respiratory dysfunction, or in patients who are morbidly obese. And in condition where administration of a reversal agent may cause severe adverse actions like dysarrhythmias and cardiac failure. So in these cases, when you are not supposed to give reversal agent, you can wait till the patient recovers on their own when you are using intermediate acting muscle relaxants. And also in cases of liver and renal dysfunction, when pharmacokinetics of muscle relaxants are altered. And also in neuromuscular disorders such as myasthenia gravis and Eaton-Lambert syndrome, which was explained by Dr. Vaishnavi in our previous talk. So what is an ideal neuromuscular stimulator? What are the, like, you have an ideal volatile agent, you have an ideal neuromuscular blocker. Similarly, you should have an ideal nerve stimulator. It should have some basic properties, like it should be battery operated, it should be portable, it should be able to deliver a constant current up to a maximum of 80 milliamperes. The polarity of the electrode leads should be indicated. That is, a cathode is always indicated as negative and the anode is red. In few of the machines, it's white also, but always the cathode is black. And the nerve stimulator should be able to deliver variety of patterns of stimulation like single twitch, train of four, tetanic,
Hello.
double burst stimulation, or post-tetanic.
Yes, yes.
And it should also enable us to monitor the evoked response. Whatever the response is seen should be monitored on the screen. So not only visually, it has to be observed on the monitor. So that also it should be enable us. So why it should have a, I said it should deliver a constant current. So why? At a constant voltage, current will vary depending upon the resistance of the skin. The two, that is the voltage and the current, are related by the equation V is equal to IR, where V is the voltage, I is the current, and R is the resistance. So skin resistance will range from 0 ohms to 5 kilo ohms. So it's a huge gap. So, and it is affected by factors such as skin temperature, adequacy of the application of the electrode, and disease states, for example, diabetes mellitus or chronic renal failure. So a current magnitude is the factor that determines whether the muscle depolarizes or not. So the pulse stimulus should, and the next thing is the pulse stimulus should last no longer than 0.3 milliseconds and be of a monophasic square wave pattern. So this will ensure that a constant current is passed throughout the stimulus. If the current is exceeding 0.5 milliseconds, for more than 0.5 milliseconds, it may stimulate the muscle directly, or it may cause repetitive firing. So always you have to see that the pulse stimulus should not longer than 0.3 milliseconds. The stimulating the motor nerve and what is supramaximal stimulus, or which motor nerve you want to stimulate, what kind of motor. See, you have to, there are many motor nerves in the body, but you should select such a nerve which has a motor element and it is very close to the skin, which is more accessible. And the contraction in the muscle, when you activate that muscle group, which this nerve supplies, must be visible. Like you have to see the response and it should be accessible to evoke response monitoring. So usually one nerve fiber will innervate 5 to 2,000 muscle fibers. So the reaction of a single muscle fibers to a stimulus follows an all or none pattern. In contrast, the response of the whole muscle depends on the all the fibers, muscle fibers getting activated. If a nerve is stimulated with sufficient intensity, all fibers supplied by the nerve will react and a maximum response will be triggered. So therefore, when an electrical stimulus is applied, it should be 20 to 25% more than that is necessary to have a maximal response. For this reason, the stimulus which has to be given when you are doing a neuromuscular monitoring should be supramaximal. So how to know what current is necessary for a certain patient? As I have already said, from person to person it changes. It depends upon the skin temperature, depends upon the disease state, everything. So to know that there is a stim pod pen which is available where you can start giving the stimulation at 8 to 12 milliamperes and go on increasing the amperes to by increments of 5. So when you get the maximum stimulus, that is taken as the maximal amount of current which is necessary. So once you have that number, you have to extrapolate it by 20 to 25% and use it as a supramaximal stimulus. So what answers does this neuromuscular monitoring give us? So the response to peripheral nerve stimulation can be used to answer few of these questions like, is the neuromuscular blockade adequate for our laryngoscopy and intubation? I already said it reduces the injuries which occur during intubation, it eases intubation. So it tells us whether it is adequate for laryngoscopy and intubation, and whether our neuromuscular blockade is adequate for surgery, and whether this neuromuscular blockade is excessive, which is not necessary, or can this neuromuscular blockade be antagonized? At what time of the stage of the operation can we antagonize these neuromuscular blockers, and whether there is complete reversal of the neuromuscular reversal has been achieved or not once the cholinesterase inhibitors have been given, or you also will know whether there is any residual block. So for evaluation of these neuromuscular function, the most commonly used electrical nerve stimulations are single twitch, TOF, that is train of 4. It may be train of 4 count or train of 4 ratio. The next is tetanic stimulation, post-tetanic count, and the last one is double burst stimulation. Double burst stimulation and double burst ratio is also there. Double burst 3 ratio is also there. They are also valuable in certain clinical conditions. So now I'll explain each one of them. So in a single twitch stimulus, a single square wave supramaximal stimulus is applied to a peripheral nerve, frequency ranging from 1 hertz, that is 1 stimulus every second, to 0.1 hertz, 1 stimulus for every 10 seconds for a period of about 0.2 milliseconds at regular intervals, and the response is observed. So this is the stimulation where at 0.1 to 1 hertz it is given, continuous stimulus is given. In the response, this is when you are using a non-depolarizing muscle relaxant. Once you give once the action starts, that is at 1 minute, it's 2 minutes and 3 minutes, the response goes on reducing and it disappears. When you use a depolarizing block, initially this is when the block depolarizing block is given, and then there is reduction in the magnitude, and once there is recovery, there is again increase in the amplitude of the response. So this is not the fade what is explained with non-depolarizing muscle relaxants. This is because this is a single twitch. You cannot make out the twitch response will only be depressed when the neuromuscular blocking agent occupies 75% of the postsynaptic nicotinic receptors. Only then the response starts getting depressed. The most useful time to apply this single twitch pattern of the nerve stimulation is at the onset, just to know whether there is any onset of the neuromuscular block, one thing, and to get what what is the supramaximal stimulus which is necessary. But it cannot differentiate between a depolarizing and a non-depolarizing neuromuscular block. And it's not useful for assessing reversal. So next, coming to train of 4. It was developed in 1970 by Ali and colleagues in an attempt to provide a better access to better this thing to assess neuromuscular block in the anesthetized patient. Advantage of TOF is degree of block can be read directly from the response, even though there is no preoperative value, which we have already done. See, because we cannot have a preoperative value, because any of these stimulations are very painful. So most of the times we don't have a preoperative value of degree of block. So this can be done without a pre-op value. And it also consists of 4 supramaximal stimulus. I said, what is a supramaximal stimulus? But here it is given every 0.5 seconds. And when used continuously, this train of 4, that is 4 stimulus is given at a stretch, is again repeated every 10th or 20th second. So this is how it looks when you give a non-depolarizing neuromuscular block. This is train of 4. Once the non-depolarizing neuromuscular blocker is given, it takes at least 3 minutes, 3 to 5 minutes. So once it starts acting, there is fading which occurs, as been already explained by Vaishnavi. So the first twitch which goes off is the 4th twitch. Next goes off. Next is the 3rd twitch. Next second stitch. Next 3rd stitch, and lastly all the 4 twitches disappear. Next, while recovering, it is the ulta phase, that is the first twitch recovers first, then the second twitch, then the 3rd twitch, and the 4th twitch. But what happens with depolarizing muscle relaxant? With depolarizing muscle relaxant, there is no fade which occurs, but the amplitude of the response goes on reducing. Similarly, in all 4 stimulus. So it goes on reducing and it may disappear and again restart. But you will not get an idea or for how much of block is there. So when a non-depolarizing, a typical pattern is observed, this reduction in the amplitude of the evoked response with 4 affected earlier than 3 followed by T2 and finally this decrement in pitch height is known as the fade. So as the non-depolarizing block becomes more intense, T4 disappears and followed by T3, T2 and finally T1. The reverse is true during recovery. During onset of a non-depolarizing block, T4 disappears at more than 95% depression of T1. T3 disappears at 80 to 85% depression of T1 and T2 at 90% of depression of the T1. So for diagrammatically show the postgraduates how you can calculate the TOF ratio. See, before giving a muscle relaxant, the response is 100% when you stimulate a nerve. This is 100%. So after giving a neuromuscular blockade, the response in all 4 responses are same when neuromuscular blocker is not given. That after giving the neuromuscular blockade, it goes on reducing like this. First, the T4 starts reducing, then T3, then T2, and T1. So this is known as a train of 4. So this T1, T2, T3, T4, and depending upon the number of responses seen on the monitor, we can say that as TOF count of 1. If only 1 is seen, that is known as TOF count of 1, TOFC 1. That is more than 95% of the receptors are blocked. If 2, that is T1 and T2, both are seen, that is TOFC count of 2, 85 to 90% of the receptors are blocked. If 3 stimulus are seen, then it is 80 to 85% receptors block and it's known as TOFC 3. And TOFC 4 when all 4 are seen, that is 70 to 75% of the receptors are blocked. So when all 4 are seen, then you can also assess the neuromuscular block by taking the train of 4 ratio. This ratio is a ratio between T4 divided by T1. For example, I've taken this the depiction. In this, the fourth stimulus is 30% of the first T1. So that is T4, that is 30 by 100 of T1, that is 0.3. So train of 4 ratio in this situation is 0.3. So initially you can check for train of 4 ratio. Once the block becomes intensified, one after the other, the responses go on disappearing, then you can check on the TOF counts. Again, it's the same with the reversal. Other way around, first you start getting the all four, first you start getting one after the other. First T1 appears, then T2 appears, then T3 appears, and T4. Then after that, you can again calculate. Once all 4 appear, you can again start calculating the TOF ratio. So during partial non-depolarizing block, the number of features correlates with the degree of neuromuscular block. Pitch suppression would equate to the TOF count of 1 or less. So reversal of the residual neuromuscular block can safely be achieved when TOF count is 3 or greater. That is, all 3 or actually, that is said, it can be achieved at 3 or greater. But according to the recent studies, if it not only TOF count 3 or greater, with all 4 TOF and TOF ratio of more than 0.9, only then reversal should be, excavation should be done. So dividing the amplitude of the fourth response by the amplitude of the first response provides the TOF ratio. One of the most useful is the in managing recovery from neuromuscular block. A TOF ratio of 0.9 to 1 should be achieved before tracheal extubation. A TOF pattern is less useful in monitoring depolarizing neuromuscular block, as I already said. Each of the 4 which has decreased equally in size, that is, there is no fade. So there is also you can't observe for recovery also. So larger doses of when larger doses of depolarizing agents are given, for example, in where patients require repeated bolus doses or infusion of acetylcholine, then phase 2 block may occur, where again the muscle the reaction will be seen like as in a non-depolarizing muscle relaxant with a fade. This block is produced by a depolarizing drug which develops a similar characteristics to non-depolarizing block. Next, coming to tetanic nerve stimulation. So tetanic stimulation consists of high frequency delivery of electrical nerve stimulation, that is at 30 hertz, 50 hertz, or 100 hertz. I've already said 1 stimulation per second is known as 1 hertz. So if you say it is 30 hertz, you are giving 30 stimulations per second and 50 stimulations per second. So the most commonly used pattern in clinical practice is 50 hertz stimulation, which is given continuously for 5 seconds. In normal neuromuscular transmission or during a depolarizing block, the muscle response to 50 hertz tetanic stimulation for 5 seconds is usually sustained. On the other hand, during a non-depolarizing block and a phase 2 block, again, after the injection of succinylcholine, the response is not sustained. That is, there is a fade which is seen. See, this is the stimulation that is at 50 hertz continuously given. Then when that is given with a, this is the control, this is when there is a moderate non-depolarizing block, there is a fade which occurs. But with the depolarizing block, there is no fade, it is just reduction in the height of the amplitude of the response. So tetanic stimulation, as I said, it's 50 stimulus given per second, and it's extremely painful. And so it limits its use in regular anesthesia practice. So except in connection with the technique of post-tetanic count, tetanic stimulation has little use in everyday clinical anesthesia. So next, coming to post-tetanic count. Post-tetanic count, during profound non-depolarizing neuromuscular blockade, there may be no response to TOF or single twitch stimulation. In such circumstances, a post-tetanic count may be useful before there is reversal of TOF, that is starting of TOF, that is the first twitch coming up. You can use the post-tetanic count. If a 5-second tetanic stimulus at 50 Hertz, what I've already explained, is administered, after no twitch response has been elicited, followed by 3 seconds later by further single twitch at 1 Hertz, there may be a response to a single twitch stimulation. Although this pattern will not be seen during very profound block, a response will be seen in the early stages of recovery, that is just before the TOF starts reappearing. This is known as post-tetanic facilitation. So that was also explained why that occurs, because of when there is tetanic stimulation, the acetylcholine is again remobilized and kept ready. So after you give a break and give 1 Hertz single twitch again, so there is a single response which occurs, and it is more in intensity, so it's known as post-tetanic facilitation. So this is what happens. This is the tetanic stimulation what is given. Then after that you start giving single twitches. So when there is deep block, so the response is here seen. So there is no, in intense block and in intense block, no response even for post-tetanic stimulation. But in deep block, there may be 1 or 2 or 3 post-tetanic stimulation response may be seen. But in surgical block, you can have up to more than 3 responses to post-tetanic stimulation. So on completion of a tetanic, acetylcholine synthesis and mobilization continue for a short period. As a result, there is an increased immediately available store of acetylcholine, which causes an enhanced response to subsequent single twitch stimulation. The degree and duration of post-tetanic facilitation depends on the degree of the neuromuscular block, with post-tetanic facilitation usually disappearing within 60 seconds of tetanic stimulation. After 60 seconds, this post-tetanic facilitation will not be seen. So the number of post-tetanic twitches is an indication of when the first twitch of TOF will reappear. For instance, the first twitch of the TOF generally returns with a post-tetanic contraction of 9. That is, I counted and said 1 to 3 may be still in deeper block. When it increases for more than 9, then you can see a first twitch response with TOF when using intermediate acting drugs. It may also be used with profound neuromuscular block is required. For example, during retinal surgery, when movement or coughing could have devastating effects. To maintain the depth of the block, this can be used as a monitor. If 2 PTCs are administered in quick succession, the degree of neuromuscular block will be underestimated. It is recommended that tetanic stimulation should not be repeated for a period of 6 minutes. So it doesn't give accurate measure of what is happening in the neuromuscular junction. So next, coming to double burst stimulation. In double burst stimulation, the 2 short bursts of tetanus at 50 Hertz at a supramaximal current are applied to a nerve. Typically, each burst will have 3 impulses lasting for 0.2 milliseconds. Each impulse is delivered every 20 milliseconds and 2 bursts are separated by 750 milliseconds. In an unparalyzed muscle, 2 separate muscle contractions of equal intensity will occur. In muscle partially paralyzed with the response to the second burst is reduced. So similar to what happens in train of 4. So this is the double burst stimulation where 3 supramaximal stimulus are given at 0.2 milliseconds difference, and first burst and the second burst are given at 750 millisecond difference. So this is how the stimulation is given, and the response. Again, the response with double burst stimulation is overpolated than the regular TOF response. So this is better read than the main TOF response. So, but similar to TOF response, there is fade which occurs. Again, there is, you can, like TOF ratio, you can have a DBS-33 ratio, where the response to the first stimulation and the second stimulation is taken as a ratio, and then divided by the amplitude of the first response, and a ratio is taken. So the ratio of the magnitude of this first known as the DBS ratio has very similar properties of TOF ratio. Tactile evaluation of the DBS ratio has been shown to be more accurate than tactile evaluation of the TOF ratio, and the neuromuscular residual neuromuscular block corresponding to a TOF less than 0.6 or lower can be detected using this method of double burst stimulation. So these are the few stimulations which can be used to monitor. So how do you monitor? How should these electrodes be? The stimulating electrodes. The electrical impulses are transmitted from stimulator to a nerve by surface or needle electrodes. The former being the more commonly used in clinical. Most of the times the needle electrodes are used by the neurologists, and we use the surface electrodes. So normally disposable pre-gelled silver or silver chloride surface electrode, that is ECG electrodes, are generally used. There are other surface electrodes with ball electrodes. The actual when you are using these silver chloride surface electrodes, that is ECG electrodes, the actual conducting area should be small. It should be approximately 9 to 11 millimeters in diameter. This is very important because if it is not sufficient, the area is not sufficient, the current produced may not be adequate to stimulate the nerve underlying. Or if it is too big, it may directly stimulate the muscle. So it should be around 7 to 11 millimeters. The skin should be cleansed properly and preferably rubbed with an abrasive before application of the electrodes. See, these are the electrostimulating electrode with an appropriate contact area. It's usually placed on the volar aspect of the wrist, 1 centimeter distal to the wrist proximal wrist crease, and the next electrode, that is the anode, that it has to be kept within 4 to 5 centimeters away from the cathode. And I already said the color coding is black for the cathode, that is the negative electrode, and this can be red or white depending upon the, here it is red and here it is white depending upon the manufacturer. So why the cathode should be distal and the anode? If the anode is put proximally, there may be hyperpolarization which may occur. So we don't want hyperpolarization. We want depolarization of the muscle to occur. So the cathode is put distally and the anode is taken proximally. And this has to be kept on the same surface of the nerve. Again, to select, to know where the nerve is very superficial, you can use the stim pot pen. So these are the ball electrodes. These are with ECG electrodes which can be used like this. So for stimulation of the ulnar nerve, it's usually best applied on the volar side of the wrist. The distal electrode should be placed up to one, as I already mentioned. The proximal electrode placed distance of 3 to 6 centimeters. The contact area is again 7 to 11. So this is a nerve stimulator which has PNS as well as neuromuscular monitoring with single twitch, DBS, tetanus, and chain of 4. So there are different muscle groups behave differently. So you should know how these muscles can be classified based on their sensitiveness to the muscle relaxants. So muscles which are highly resistant but with faster onset of block are diaphragm, adductors of the larynx, and the corrugator superciliary. Muscles which are very sensitive with faster onset of block are airway muscles, especially the pharyngeal muscles. Muscles which are highly sensitive but with delayed onset are peripheral muscles, including the adductor pollicis. So when we take adductor pollicis to monitor, so this is the last, because there is delayed onset of a block in these things. So when you use this, you would have had sufficient relaxation in the for intubation. So sites of nerve stimulation, which may influence our monitoring site and the clinical response. I already said it's adductor pollicis. You use the ulnar nerve. It's ideal site because it's most readily accessible during surgery, and it is sufficient for surgery of the upper and lower extremities. Corrugator superciliary, that is a temporal branch of the facial nerve, is supplied by the temporal branch of facial nerve. It is localized in the medial portion of the eyebrow. The response is seen on the medial portion of the eyebrow. It reflects the extent of neuromuscular block at the laryngeal adductor muscles and the abdominal muscles. So the neuromuscular blockade at the corrugator superciliary ensures optimal timing for intubation and for surgeries within chest and abdomen. Other nerves which may be used are median, posterior tibial, common peroneal, and facial nerve for orbicularis oculi in special situations. So quantitative measurements of the neuromuscular blockade. What we saw till now are objective methods. Now to quantitative methods are mechanomyography, electromyography, kinemyography, phonomyography, and compressomyography. The measurement of the evoked mechanical response of the adductor pollicis muscle. Again, here ulnar nerve is stimulated. There are no clinical devices because it is bulky and cumbersome, but it's precise, it can be reproducible, it's a gold standard. But usually the most commonly used technique is the acceleromyography. Electromyography is when a muscle action potential is recorded with when there is a nerve stimulation. Datex, Omeda, NMT electrosensors are available. They are best indicators of pure neuromuscular function. They are comparable with mechanomyography, available for many sites, but free muscle movement is not required here. Influenced by other electronic devices in the OT like the diathermy or the local temperature. So I already said this is the acceleromyography, is the most widely used, where the acceleration of the stimulated muscle is calculated using a piezoelectric sensor. The devices available are TOFR, watch, Infinity Trident NMT Smart Pod, or 3D AMG StimPod TOF scan. This is easy to handle, suitable for any free moving muscle. 3D transducer is there to measure more precisely the muscle movement. But it cannot be interchanged with EMG or MMG. There may be some TOFR overestimation. The baseline TOFR should be more than 1. Next is kinemyography, phonomyography, and compressomyography. Measurement of kinemyography is generated by bending of the piezoelectric sensor strip placed between the thumb and the index finger. A Datex Omeda mechanosensor is available. It's easy to use. Only thing is free thumb movement is required and good strip placement between the fingers is required. Phonomyography, where measurement of the low frequency sounds are evoked by muscle contraction, but no device is available. But it's easy to apply, usable for many sites, good correlation with the other things. Compressomyography, again, cuff is available, where modified non-invasive blood pressure cuff, measuring the block depth by brachial plexus stimulation through electrodes attached on its inner surface of the cuff. But here there is no need for arm to be free, but again it's not interchangeable. TOF cuff or TOF more than 0.9 correlates with well with MMG of TOFR more than 9. So now coming to different levels of block, neuromuscular block. That is about the different devices available for quantitative estimation of the block. Now coming to different intensities of the neuromuscular block. I already mentioned there is intense block, deep neuromuscular block, moderate or surgical block, and recovery from neuromuscular block. So when do you say it's very intense neuromuscular block? Within 3 to 6 minutes of injection of an intubating dose of a non-depolarizing. What is intubating dose? That is the ED95, twice or thrice the ED95 dose of a non-depolarizing muscle relaxant is given. So after giving, within 3 to 6 minutes, the patient goes in for a intense neuromuscular block. In this period, it's also known as period of no response. No PTC is seen, no TOF count is seen. And at this stage, it cannot be antagonized with a cholinesterase inhibitor. But with high doses of sugammadex, that is 16 milligrams per kg, can antagonize intense block, which is caused by rocuronium and vecuronium. But it's not advisable. Again, deep neuromuscular block, this is intense block is followed by a period of deep neuromuscular block during recovery, where the PTC is more than or equal to 1, but again, there is no TOF ratio or TOF count. Usually impossible with, again, here in reversal is not possible with cholinesterase inhibitor, but it can be antagonized with sugammadex of 4 milligrams per kg after few minutes. Next is moderate or surgical block, where the first response of TOF appears and TOF count may be between 1 and 3. So antagonism with neostigmine should not be initiated at this level. This is the level where the surgery can be taken, can be continued. But here you should not try to antagonize, should not be initiated till at least 4 responses are observed, because if you try to antagonize at this level, you may increase the block. So you may increase the duration of the block. So never try to antagonize with anticholinesterase inhibitor at this stage. Recovery from neuromuscular block, there is return of 4th response in TOF. PTC is not applicable because already TOF has come, and TOF count of 4, it is the reversible stage. So these are the monitors, as I've already told you, this is the accelerometer where train of 4 is seen, and this is also a accelerometer with DBS stimulation. So when TOF ratio is 0.4 or less, the patient is generally unable to lift the head or arm. So most of these things will be covered by my next speaker, who will be talking on residual neuromuscular paralysis. So I'm going to skip this slide. So on conclusion, neuromuscular block should be monitored for all patients who receive non-deep neuromuscular blocking agents during anesthesia. This helps in guides in dosing the neuromuscular blocking agents and the reversal agents to assess the degree of recovery, and quantitative methods are preferred like acceleromyography or mechanomyography. Satisfactory recovery from neuromuscular block does not occur till TOFR is more than 0.9. So global guidelines for neuromuscular monitoring during anesthesia is needed to reduce postoperative residual relaxation and improve patient outcome, because neuromuscular monitoring is not one of the mainstays of minimum mandatory monitoring, which is recommended by most of the guidelines. So it is better to add neuromuscular monitoring for regular use, so that there is no residual paralysis which occurs in the patient and better outcome of the patient. Thank you. This is our institute where I work.
Thank you, Dr. Archana.
Thank you, sir.
Your elaborate presentation and monitoring is useful, but not practiced regularly. Few questions are there, we will ask in the end of the lecture.
Yes, sir.
Now I call upon Maitreyi for her lecture on residual neuromuscular palsy.
Good evening, sir. Good evening, everybody. The topic of discussion for my class today is residual neuromuscular blockade. I'm Maitreyi, second year postgraduate in JSS Medical College, and I'll be discussing on residual neuromuscular blockade today. It is defined as postoperative paralysis or weakness due to incomplete or absent antagonism of non-depolarizing muscle relaxants. It is more common with long-acting neuromuscular blockers, and it is more of a cumulative effect of neuromuscular blockers. They depot from the sites and enter the blood and cause recuriorization. Quantitatively, traditionally, ulnar nerve and adductor pollicis is used as unit, and TOF ratio recovered to 0.7 with sustainable head lift, eye opening, hand grasp, tongue protrusion, and vital capacity of more than 15 ml per kg body weight was considered. But now the gold standard is if the TOF ratio is more than 0.9 in order to prevent the residual neuromuscular blockade. The signs and symptoms include generalized weakness, blurry vision, diplopia, facial weakness and numbness, and inability to perform head lift, hand grip, eye opening, tongue protrusion, inability to swallow or smile, and inability to perform deep vital capacity breaths. The most inclusive and precise definition of residual neuromuscular blockade should include not only the objective and quantifiable monitoring data, like of TOF ratio demonstrated with axilleromyography, mechanomyography, or electromyography, but also clinical evidence of impaired neuromuscular recovery, like swallowing impairment, inability to speak or perform a head lift, diplopia, and generalized weakness. The consequences are upper airway, pharyngeal, and esophageal muscle palsy, which will result in increased risk of aspiration and increased risk of airway obstruction. The laryngeal muscle palsy will increase risk of aspiration, impaired phonation, impaired cough, and the respiratory muscle palsy will impair oxygenation and ventilation. Factors affecting residual neuromuscular blockade are patient factors like age. The older adults are at a higher risk, and patients with comorbidities like renal dysfunctions, liver dysfunctions, and neuromuscular disorders are at a higher risk. And patients who are already on medications which are known to affect the neuromuscular transmission, like anti-seizure medications, are at a higher risk. The intraoperative factors which affect are the type of neuromuscular blockers used. That is, if the intermediate acting agents are used, then the patient will be at a lower risk of residual palsy, whereas if long-acting muscle relaxants are used, then the patient will be at a higher risk. Also, the dose of muscle relaxants used intraoperatively shows an effect. And if the neuromuscular monitoring, like qualitative and quantitative, are used, then the patient will be at a lower risk. And the depth of neuromuscular blockade, the deeper the blockade, more will be the risk. Also, type of anesthesia, like if inhalation anesthetics are used, then the patient will be at a higher risk. And if TIVA is used, then the patient will be at a lower risk. Factors related to the antagonism of the neuromuscular blockade. If the use of reversal agents is used, like neostigmine, pyridostigmine, edrophonium, and zigamadex, then there will be a lower risk of residual muscle palsy. And the dose of reversal agent will also play a role. Also, the time interval between the reversal agent administration and quantification of neuromuscular blockade is important. The postoperative factors like respiratory acidosis, metabolic acidosis, hypothermia put the patient at a higher risk. Also, the drugs which are administered in post-anesthesia care unit, especially opioids and antibiotics, play a major role in residual neuromuscular palsy. The adverse effects of residual neuromuscular blockade. There have been studies in which awake volunteers have participated, and the following it has observed that pharyngeal dysfunction and reduced upper esophageal sphincter tone is there. The residual blockade, the subjects were administered with a rocuronium infusion, which was titrated to a TOF ratio of 0.5 to 1, and MRI was done, which was used to measure the supraglottic airway diameter and volume. The figure A here, it shows before the neuromuscular blockade, and the figure B is at a steady state of TOF ratio of 0.5, figure C at a TOF ratio of 0.8, figure D after the recovery of TOF ratio to 1.0, and figure E 15 minutes later. As it is seen here, the partial paralysis evokes an impairment of upper airway diameter and increases during the forced inspiration. The surgical patients whom we see day to day are prone to hypoxemic events, airway obstruction, unpleasant symptoms of muscle weakness, delayed PACU stay, pulmonary complications, ICU admission due to ventilator inadequacy after reversal, and cardiac arrest. This may be due to hypoxia, which is due to inadequate reversal, or asystole due to anticholinergics. Also, the inhibition of hypoxic ventilatory response. The residual neuromuscular blockade inhibits hypoxic ventilatory control while leaving the ventilatory control due to hypercapnia unaffected. There was a study in which after the administration of atracurium, pancurium, and vecuronium, the hypoxic ventilatory response was attenuated by 30% at adductor-polysis of TOF ratio of 0.7, which is depicted in the yellow graph, and returning to normal, that is spontaneous recovery after a TOF ratio of more than 0.9 as compared to the controls, which can be seen in the graphs given below. The diagnostic tests, the clinical tests which are most reliable are sustained head lift for more than 5 seconds, sustained leg lift for more than 5 seconds, and sustained hand lift for more than 5 seconds. The unreliable factors are tongue protrusion, opening of eye, phonation, and generation of tidal volume of more than 5 milliliters per kg body weight. The qualitative tests and quantitative tests, when we are provided with a peripheral nerve stimulator, using the visual and tactile assessments and response to stimuli, the qualitative tests can be done, and the quantitative tests which record, quantify, and display the response to stimuli can be done. The prevention. If we are in a setup where there is no neuromuscular monitoring, then anticholinesterase should not be given until some evidence of recovery of muscle strength is observed, because administration of anticholinesterases during deep levels of paralysis may delay the neuromuscular recovery. Decisions relating to the use or avoidance of anticholinesterase should not be solely relied on clinical tests of muscle strength. If we have a provision of TOF monitoring, then the qualitative and quantitative. If the quantitative you have the provision, then TOF count of 1 or no response. If there is no response, then you have to delay the recovery until reversal is complete. If the TOF count of 2 or 3, then anticholinesterase can be administered. That means neostigmine dose of 70 micrograms per kg body weight. If there is TOF count with observed fade, that means if there is only qualitative and you observe a fade, then moderate doses of anticholinesterases are to be administered. And if it is quantifiable and it has a TOF ratio of more than 0.4, then the same thing. You have to administer moderate doses of anticholinesterases. If there is no fade observed, that means that TOF ratio is corresponding to quantitative data of 0.4 to 0.7. Then mild doses of anticholinesterases can be administered. If the TOF ratio is more than 0.7, then you need not administer any anticholinesterases. The conditions where neuromuscular monitoring is essential. As Archana ma'am had already discussed, I'm just repeating the same thing. The conditions where the prolonged infusions of neuromuscular blocking drugs are used, prolonged surgery or anesthesia, the conditions where inadequate reversal may have devastating effects like severe respiratory distress and morbid obesity, and the conditions in which the administration of a reversal agent may harm the patient like tachyarrhythmias and cardiac failure, and the patient who has renal or liver dysfunctions in whom the pharmacokinetics of our drugs are altered, and patients with neuromuscular disorders such as myasthenia gravis or Eaton-Lambert syndrome. Treatment of the residual neuromuscular blockade. First, we have to support the airway, breathing, and circulation, and rule out other potential causes. And we have to see whether it is really a neuromuscular blockade or not. Check the nerve stimulator, check the electrodes, and use a different nerve-muscle combination. Wait, and you have to ventilate the patient. And we should always treat the potentiating factors which prolong the neuromuscular blockade, like inhalation agents, opioids, acidosis, hypothermia, hypercarbia, and hypoxia. All these factors are to be corrected, and we have to support the airway, breathing, and circulation of the patient. If you are working in a setup where there is no proper neuromuscular monitoring, always look for the clinical signs and be vigilant enough to look for the residual neuromuscular blockade. Because eternal vigilance is our slogan for ISA, and I thank all the professors who have given me this opportunity to present it. Thank you.
Thank you. Thank you, Maitri. Am I audible?
Yes, sir.
Yes, sir.
Ah, yes. And all the 3 presenters are presented the whole chapter on the neuromuscular junction in a elaborate way. And it is, I congratulate them for the hard work they have done to have a beautiful presentation and informative presentations. Now, there are a lot of questions in the chat box. And one question is, why the non-depolarizers should be used after depolarizer? The patient comes out from the depolarization. The question is addressed to the first speaker.
Why the non-depolarizers should not be given? I didn't get the question.
Yes, after the, is there any evidence physiologically?
As such, there are no studies which tell that there is a time limit after which a non-depolarizer can be given when we have given depolarizer first. So it is only a practice that is done on a case-by-case basis. Some anesthesiologists, they give before the patient comes out totally out of scoling, and some practice giving it before the patient is totally out. But as such, there is no evidence, scientific literature giving a scientific explanation or a time limit as to when we have to give the non-depolarizer after giving succinylcholine.
It is true, but in our practice, we always try to give after they come out from the depolarizer, because people are always afraid of scolinopnia. Yes. And getting confused at the end of the surgery. But anyhow, sometimes it is the patient comes out with a bout from the depolarizer, yes, which may be injurious to the patient as well as to everybody, and yes, the operation theater. So as you say, there is no evidence as such. There is no physiological evidence is also there. Yes. Anybody want to comment on that?
Yes, sir. That's the only reason, because before they come out of depolarizers, we don't give non-depolarizing muscle relaxant. Only thing is to know whether they have atypical pseudocholinesterase. In case the patient doesn't recover at the end, we'll not be able to know because of that.
Yes, that is the classical fear every one of us have, because we want to see the patient comes from scoling. And one more question on the chat box.
Sir, I just want to comment here.
Yes, sir.
Ideally, yes, theoretically speaking, so we should not use a depolarizer first and a non-depolarizer later. Because actually, when we are using an agonist and then giving an antagonist, we are totally confusing the neuromuscular junction.
Yes, true.
Theoretically, it is wrong practice first to give an agonist and then an antagonist. But since ages, we are practicing this and we are not having any problem. But as such, it is very important for all the postgraduates to know that, when you give a depolarizer, see that some movement is there from the patient for you to give a non-depolarizer. Otherwise, you just wait. So many times what has happened is, of course, recently, in Bangalore only, it's about a week back. So they have given depolarizer, and without waiting for some amount of recovery, they have given a non-depolarizer. And afterwards, they found out that the patient is a Vaishya patient. Usually, they carry this genetic problem of atypical pseudocholinesterase. Then they had a lot of problem. They had to ventilate the patient for almost 6 to 8 hours. So that is why for all postgraduates, it is very important to see that some recovery is there from depolarizing muscle relaxant, like succinylcholine. Then only you give non-depolarizer. There is no problem as such.
Yes. It is true, Dr. Gurudev. But one more thing, you would have also observed that many of the neuroanesthetists, and if in case of difficult intubation, they use suxamethinium. Immediately followed with a non-depolarizer. They don't want any bucking or things like that. And if anything goes wrong, they put on the ventilator for a couple of days and get along with it.
Sir, can I intervene, sir?
Yes, sure.
Sir, there is a corollary question in the chat box. If you have given succinylcholine and to position the patient, instead of waiting, if you give a non-depolarizer, is there any way of detecting it by neuromuscular monitoring? So this question will go to Dr. Archana Madam, I believe. It is a question related to this thing. And again, I wanted to tell you, in neuromuscular, in neurology cases, it is easy, but the problem mainly comes in the cataract surgery. If it is a young boy or anything cataract, if you are giving succinylcholine, you cannot wait for the patient to recover, then we may be using a non-depolarizing blocker. At that time, as chairperson pointed out, it can come. This is to enlighten the postgraduates, the problems can occur. Because even for a cataract case, we have transfused blood and we ventilated for 6 hours. That is 15 years back. So now things have come around. The anesthesia has developed very much. But I think this related question can be taken up now. Whether
if we are using an objective monitoring of evoked response, it's not a problem. You can always get a TOF ratio or TOF count when we are using TOF monitoring, when you are giving a non-depolarizing muscle relaxant.
Madam, his question is, if immediately non-depolarizing blocker is used, can it be differentiated?
Main thing is what is necessary for the cataract surgery or surgery like that. So when you are using succinylcholine, as already said, there is no data to say you cannot give the non-depolarizing before the patient comes out of depolarizing. Only what his question is to have the depth. They have given non-depolarizing muscle relaxants early. So again, the monitoring may be similar to non-depolarizing muscle relaxant and to check for TOF counts.
So you meant to say that it can be differentiated by monitoring neuromuscular junction.
It will not tell us whether it is depolarizing block or a non-depolarizing.
That's what he is asking. That's what he is asking.
Can be monitored, sir.
That's what he is asking.
Yes, sir. Only the depth of the block can be monitored.
Sir, if the patient has been given succinylcholine and the patient has not recovered, that means, if you use a TOF, so no response will be there, because the amplitude of each one of the, the twitch there will be almost zero when the patient has got deep with the depolarizing muscle relaxation. So when you use the non-depolarizer also during that time, so the effect is almost same. That means the TOF count and TOF ratio will be zero. So till the patient recovers from the depolarizing block and the non-depolarizing block, so you won't have any response.
That is a good question. A good question he has asked in the chat box.
Very interesting question, and definitely
cannot be differentiated.
You cannot differentiate what kind of a block you have, because there won't be any TOF ratio, there won't be any tetanic response. Even post-tetanic count also will be zero, because both the drugs would have produced a deep and intense block. So with neuromuscular monitoring, you cannot differentiate.
This type of clarity will not be there in the regular teaching schedule. This is a good question.
Correct, sir. Very interesting question.
Interesting. Chairperson, sir.
There is one more question. At what train of 4 ratio you will start reversing?
Sir, as already said, initially it was more than 0.7 that said, sir, but recent literature say only after more than 0.9, sir.
So for reversing,
almost equal.
Sir, for extubation, what I have said. For reversing, once the third count is come, you can always think of reversing, sir, as I have already said in my talk, sir. But extubation should be done only after the TOF count is more than 0.9, sir.
So, but for reversal also, ideal would be 0.4, train of 4.
Yes, sir.
Ideally.
Yes, sir.
So that, you will have a faster reversal when already the patient has got all the 4 TOF count is there.
But as
And the
already
TOF
said,
ratio is 0.4.
of neostigmine, sir.
Yeah, that is what is called as the TOF of 0.4 is called as the block for reversal. That is also called as a block for reversal. So early reversal will occur once the TOF ratio is 0.4.
But you may have to give a larger dose of neostigmine, sir, at that level if you are thinking of reversing the patient.
No, at 0.4 you don't require larger dose. But when you have only train of 4 count of 2 or 3, then you have to give larger dose.
Okay.
Train of 4 of 0.4 means all the 4 responses are already present.
Already come. Only a trio of is seen only after, ratio is seen only after all 4 happen.
Fourth response is also present.
The 0.9 train of 4
Sir.
in the recent literature, they
Yes,
said, Archana, Dr. Archana,
Yes, sir.
can you hear me?
Yes, sir.
The 0.9%,
Yes, sir.
the recent literature you have said, in what basis they tell this?
Sir, because most of the cases was already told, sir, many of the problems which are associated, like patient may go in for hypoxia, there may be sufficient vital capacity, breaths cannot be taken, total tidal volume.
Shall I add one more point regarding?
Yes, sir. Yes,
because
sir.
the receptors in the carotid bodies,
Yes, sir.
which are sensitive for hypoxia, if they get blocked by these drugs,
Yes.
and the hypoxic response will not be there. So it is believed if it reaches 0.9, even those receptors in the carotid bodies will be neutralized. That may be the literature says, I read somewhere. So I want to share this with you. Huh? Then one tricky question. Somebody asked, Dr. Parsad, he has asked, train of 4 after a brachial plexus block. What will be the response to the train of 4 after brachial plexus? It will be normal.
Sir?
It should be normal only.
How, sir?
What? After brachial plexus block,
Yes, sir. Motor block is there, sir.
after brachial plexus block, what will be the train of 4 response?
So usually there should be no response, sir.
No. You are only testing at the periphery. It is in
Yes,
the
sir.
brachial plexus is in the center, almost in the
No,
distal
but
only.
we usually select the adductor polysis, sir. For
No, whatever it may be,
on that site it may not be there, but other
it is only a local test.
only
So
on that
train of 4 should be normal only.
yeah, on that limb you may not get TOF, sir. Other limbs
No.
other sites
You will get it because you are no. You will be getting. You are only testing the muscle. There is no block in the
Sir, if
neuromuscular
it is
junction.
on the
So you should be
same
getting you.
limb.
This
No,
is a
no.
tricky question from Parsadi from Tanjavur, I think.
Dr. Kannan sir, I fully agree with you because we are directly stimulating the nerve
Yes, sir.
at the periphery.
Yes.
So the block may be higher up, but the nerve
Higher
is
up.
still intact.
Good.
So since we are stimulating the nerve, the TOF will be normal.
Sir.
The TOF ratio will be there, it will be normal. Absolutely, there won't be any problem in monitoring the TOF ratio or whatever it may be, neuromuscular junction monitoring. Even if you have given
there should not be
brachial
any
plexus
disturbance.
block.
Sir, even on the limb which is blocked, sir.
Yes, because
Yes.
you are blocking high up,
Higher up.
but lower down, you are directly stimulating the nerve here.
Stimulating the nerve.
Yeah,
Yes.
directly
This is-
stimulating the nerve. Electric current is directly producing and stimulating the nerve.
Yes.
So the TOF and whatever the neuromuscular
Yeah, it's all
junction
peripheral.
It should be
parameters
normal.
will be normal.
It
only.
should be normal.
Yeah.
Sir, Chairperson,
This is a question from Parsadi from
Sir.
Tanjavur, I think.
Chairperson, sir, he has put up another
Yes, sir.
tricky question also. Rather, he has supplemented. He says, by neuromuscular monitoring, we can differentiate between phase 2 block and this ND non-depolarizing block. I think that A1 Logics, please unmute S. Patsardi and allow him to speak on that because his question is not clear.
Sir, participants can unmute themselves.
Yeah, Dr. Patsardi, with the chairperson's permission, I request Dr. Patsardi to unmute himself.
Sir, good evening.
Parsadi is here. Good evening, sir. Good evening.
Tell me, Patsardi, your question.
Complete intubating dose only will produce no response.
Correct.
Now, if you give scoline and after that, we are not going to give 0.6 milligram per kg of atracurium. We are going to give only 0.2 to 0.3 milligram per kg of atracurium. This is not going to produce. There will be some reaction, at least the PTC will be there, unlike scoline. So we can differentiate if it is going to be after 5-10 minutes. Yes, it is possible. That is what is my concept about this difference in opinion about others.
No, if it is given immediately, then at that particular moment, because the depolarizing block also will be complete. So at that moment, Trina-4 will be absolutely absent. Even tetanic response will not be there. So at that moment, I am talking about. Afterwards, of course, definitely you can differentiate.
After a few minutes also, it is not going to be easy. You are going to check only between scoring problem and atracurium problem. The scoring problem also cannot be differentiated if you test within 1 minute, half a minute.
Correct.
So
that's what I am telling.
you are going to have a problem only after 4-5 minutes, 6 minutes, when the scoring is going to disappear. That time, if you are going to give without your response to scoring or some response to patient, some gag reflex has not come, you are doing non-depolarizer, then we can differentiate because we are going to give half the dose.
No, definitely afterwards we can differentiate, sir. But one problem there, one of the question also says that suppose the patient has got a scoring apnea or atypical pseudocholinesterase. Then also you have not tested and you have given non-depolarizer. Then you will not be able to differentiate.
So both are right. Dr. Parsardi, the question is when the patient is having a phase 2 block, whether it will be possible to differentiate. That is the thing. It is not, the question is not differentiating between depolarizing and non-depolarizing black. Thank you. Over to chairperson. Sir, chairperson, sir.
So, sir, there is no more discussion.
The questions are there, sir. Chat box questions.
இல்ல இருக்க பார்க்க முடியல.
Sir, I will tell that chat box questions.
Sure.
What are all the objective criteria for extubation apart from subjective features explained? Madam, Archana madam, what are all the objective criteria for extubation?
Sir, as already mentioned, sir, the vital capacity should be good, the tidal volume should be good, and the other objective things what Dr. Maitri has mentioned has to be taken care, sir. If you don't have a neuromuscular monitoring, usually that's what we have been doing all these years, sir. We don't use a neuromuscular monitoring for all the cases.
Is it not mandatory to use neuromuscular monitoring when we are using long-acting muscle relaxant?
Sir, it has to be done mandatory, but as such, there is nothing mentioned, no guidelines that it has to be mandatory. But most of these days, we are not using any of the long-acting muscle relaxants. Most of the drugs we are using are intermediate-acting muscle relaxants.
Now, asystole due to anticholinergics, how?
So it must have been for anticholinesterase, sir. By probably.
Yeah, he has mentioned anticholinergic. It is for neostigmine. I think he has asked Dr. Anil Kumar. It may be anticholinesterase for neostigmine. Anyway, Sir can explain how neostigmine produces asystole. That is actually produces bradycardia and asystole.
No, sir, I got it. In the print, it was there. So I thought there may be some other mechanism which is causing. So I just asked it.
Thank you.
Thank you.
Thank you. Then another question asked, when inhalation agents are used, when the patient is under ND blocker, how to assess the neuromuscular monitoring? I think Dr. Anil Kumar has asked the same question.
Yes, sir, about inhalation anesthetics and about dexmedetomidine, both he has asked.
He has asked.
So it doesn't come in our way of neuromuscular monitoring, sir. Actually, there may be little delay in the recovery, but as such, there will be no problem with the neuromuscular monitoring when it's used along with the inhalation agents or with the dexmedetomidine.
No, my question was dexmedetomidine, if it doesn't interfere.
Yeah.
But many times when we want neuromuscular monitoring, suppose for scoliotic surgery, what we have observed is whenever we use TOF monitoring, the TOF will not become 0.9, where that is what the required by the surgeon and the neuromuscular technician for monitoring the to avoid any nerve tissue damage. But when we use inhalation agent, though we are using TIVA, but many times it is observed that when you use inhalation agent, the TOF will not reduce less than 0.6. Sorry, it will not rise more than 0.6 or 0.7. It will always be 0.9. Maybe probably I thought because of this central effects, it also interferes with TOF. That is my observation when we use for TOF for neuromuscular monitoring, particularly in these surgeries. Yeah. Yes.
Maybe it's always, it potentiates the action, but on the TOF monitor, how far it is, this thing I am not very sure.
Now, usually the inhalation anesthetic agents will not produce much interference with the neuromuscular monitoring, because many of the times we may have to extubate the patient when the patient is deep with the inhalation anesthetic agents. So in such situations, definitely in order to differentiate whether the patient is deep with neuromuscular blocking agents or inhalation anesthetic agents, definitely you can use the neuromuscular monitoring. So if Trina 4 is 0.9 and the patient is deep with inhalation anesthetic agents, so especially like, the patients who with bronchial asthma patients or COPD patients, where we don't want to extubate them when they are completely awake. Sometimes, the deep extubation is also usually done in order to prevent.
But his question is TOF will not raise.
So that's what any acute, attack of bronchial asthma. In such situations, definitely TOF can be used, and TOF will be normal once the patient has completely recovered from the neuromuscular blockade, and he may be deep with inhalation anesthetic agents. So you can use even a LMA, and then you can extubate the patient. So allow the patient to recover completely by spontaneous ventilation. That is there. But as Anil was asking about the dexmedetomidine, what has been found is definitely when dexmedetomidine has been used, so it decreases the requirement of neuromuscular blocking agents. But I don't know whether it can also have an effect on the neuromuscular junction. Actually, nowhere it is there. But it definitely extends the duration of action of non-depolarizing material.
Sir, theoretically, when we are testing neuromuscular monitoring, the central depressants will not have a role in that. Anyway, I ask, this is a corollary question not related to this subject. I want to ask Dr. Anil, just because he was talking about scoliotic surgery, I think he is trying for a leg raising test or like that. Whether they are using evoked potentials in scoliotic surgery?
So, sir, Dr. Anil is asking about that only because we routinely do neuromuscular or neuromonitoring during scoliotic surgery. So in that neuromonitoring, even it also records the Trina 4 also. It also continuously monitors the neuromuscular junction also. So that, it will tell us that whether there is any effect of neuromuscular blocking agents in order to prevent any movement of our motor response. So that's how it also records the continuously TOF. That's what Dr. Anil is telling about the TOF ratio. He says that it will never go above beyond 0.6 with the dexmedetomidine. That's what he has observed. That is what he is telling, but it has to be studied actually.
I know no more questions in the chat box. Chairperson, sir, no more questions in the chat box.
Yes, sir. Yes. And thank you all for the nice presentation and a nice evening, academic evening we had. Over to Dr. Meenakshi.
So one thing I just want to tell all the postgraduates, neuromuscular blocking agents are not anesthetics. They should always remember that, because neuromuscular blocking agents, they are hydrophilic, they cannot cross the blood-brain barrier, they do not act on the brain. So majority of the postgraduates, what they do is whenever the patient moves, they try to give an additional dose. Patient is moving because he is light. So you should deepen the plane of anesthesia rather than trigger happy and just keep on giving an additional doses of neuromuscular blocking agents. So that they should always understand. Keep the patient deep with,
because of this blocker, the incidence of awareness is high. Because of these blockers, incidence of awareness is high, especially like surgeries like laparoscopy and other
I think
That's why they should understand that the patient should be kept deep with inhalational or IV anesthetic agents, not by neuromuscular blocking agents.
That is the reason is that our Professor Ravi Shankar Pondicherry, he used to say, relaxant is for the surgeon, volatile agent is for the patient.
Correct.
So,
Fantastic.
that is a good terminology.
That is, ALM sir, that is given in book Miller. When the patient moves during operation, if you give relaxant, it is comfortable for the anesthetist. Unless you add agent or narcotic, it is never comfortable for the patient. That is
only after so much of experience, we could derive these statements. And before I pass on the stage to the president, I personally thank the team of JSS, the ladies team, and Dr. Gurudat has done us some favor by introducing this team. At the same time, now the glamour of Dr. Gurudat may be decreasing, because we thought in Mysuru he is a popular speaker, but from JSS, I think even from the postgraduate level to this professor, they are doing very well, and the clarity, the tone, the subject, the confidence they show, it is a remarkable achievement. And I personally thank once again Dr. Gurudat, because he has not blocked the subordinates. He has facilitated, and he is impulsive. So he was not a blocker. A good teacher is a facilitator. And to the terminology of a good teacher, he has facilitated his team. And when we requested him to talk, he said, I will project my team. And he has done commendably well. The profuse congratulations to the 3 faculty and the chairperson, my good friend, Dr. Kannan. And I request Dr. Gurudat sir to identify this sort of teams, not only in Karnataka, throughout the country, for us to project them, their teaching skills. Now they have done tremendously well, and it is a good teaching capability they have projected. Over to President Dr. Suresh Kumar sir.
Thank you, sir, for the nice comments. Thank you very much, sir.
It is heartfelt, sir. It is heartfelt.
Okay. Thank you, sir. Thank you, sir.
Thank you, sir. President, sir, for a vote of thanks.
Thank you.
Dr. David.
Yes, sir.
Vote of thanks.
Good evening to all. On behalf of ISA Pudukkottai, first of all, I would like to thank our academic chairman, Dr. ALM sir, for success of conducting a Pudukkottai exam. And I would like to thank chairperson, Dr. Kannan sir, former professor of Similarly Medical College, for sharing his experiences. And I extend my thanks to our speakers, Dr. Vaishnavi ma'am and Dr. Archana ma'am and Dr. Maitri ma'am, for a very useful academic and informative session. And I also thank Dr. Gurudat sir for sharing his experiences, and other faculties, postgraduates, and our sponsor Acetylcholine and A1 Logics for making this event successful. Thank you.